Good evening, everyone. On behalf of Maharashtra State IIP, myself, Dr. Sunita Ingle, extend a very warm welcome to all the dignitaries who are present on this virtual platform, as well as all the viewers who are watching this program on our YouTube Live. We have with us today Dr. Hemant Gangulia sir, who is the Maharashtra State IIP President, Dr. Jay Bhandarkar, Convener, Dr. Amol Pawar, Secretary of Maha IP, Dr. Mahesh Moite sir, Dr. Ramakant Patil sir, who is our expert for today's session. And I also welcome the case presenters, that is the moderators, Dr. Anand Deshpande sir from Pune, Dr. Anjali Gokarn from Palghar, and of course the participating teams who are from Mumbai, Team Mumbai and Team Nagpur. So I welcome you all, and I will now request Dr. Hemant Gangulia sir to give his opening remarks.
Thank you, madam. Good evening and namaste to all the respected dignitaries on the dais. Today we have expert Dr. Ramakant Patil sir, CIPV member for 2022, as well as the moderators Dr. Anjali madam from Palghar, as well as Dr. Anand Deshpande from Pune, and both two teams, Nagpur and Mumbai. And actually, though I am IIP president, but so much high level secrecy is maintained. Just when I prepared the slides, then I got to know these are the teams and these are the experts who are going to present. So very high level secrecy is maintained in this. This is the 6th episode of Maha IP case challenge. And just I feel, well, whenever visiting, seeing this 6th episode, all we practicing as well as pediatrician, while seeing this session of Maha IP case challenge, it really gives an introspection to practical pediatrician who practice how to go about, and really it gives an introspection the way what we practice and actually what should be done, and all these things gets so much crystallized and synchronized with this episodes of Maha IP case challenge is a wonderful. So all the best wishes to the both teams. I am very hopeful that these two presenters will have a good cases here, and they will be cracked by the two teams efficiently. As well as I acknowledge the presence of Mumbai President Dr. Rajesh Chokhani sir also, and Dr. Mahesh Moite sir, and all the dignitaries on the dais. Thank you very much.
Thank you so much, sir. Now I will request Dr. Moite sir to say a few words, sir. Over to you, sir.
Thank you very much, Dr. Sunita. Again, pleasure to have this session, the 6th one back to back, and enthusiasm is not died out. It's still maintained because of the quality of program that we are providing over last 6 months. And all of us know the concept. Concept is not to perhaps, I mean, diagnosis is not very important. What is important is the approach. The whole thing is all about approach from a clinical history taking, and then followed by clinical examination. And look who is there today. We have Dr. Rajesh Chokhani. I mean, I should not say anything more than that. I mean, the person whose name is for approach all along. So we have been teaching the students over last time, Dr. Rajesh Chokhani with Dr. Ambedkar sir over last 22 years about the same approach. And look at the program's quality today. It has reached. Dr. Rajesh Chokhani himself is there to sort of grace the occasion. I thank him and congratulate him for coming all the way to this class, because that really gives sort of a level to this platform. And with that, it's over to Dr. Sunita Ingle for taking over. As Hemant has already said, the secrecy is maintained. Though we know the teams now, we still don't know who is going to take that, which case. So that's how the program has been run, has been going on for last 6 months. And it's over to Dr. Sunita Ingle, followed by Dr. Shilpa. Thank you.
Thank you so much, sir. Now I will introduce our expert today. Our expert for today's session is Dr. Ramakant Patil sir, who's from Nasik. He is the EB member of Central IIP 2022. Also the Chief Organizing Chairperson, Maha Pedicon 2022, which is going to be held in Nasik this year. Sir has been the past Vice President of IME and past Maha IP State Secretary also. His main field of interest is in critical care and asthma. And he's an avid trekker and a sports person also. I will request Dr. Ramakant Patil sir to please say a few words, sir.
Thank you, Sunita Ingle madam, Maha IP Gangulia ji, Jay Kumar Bhandarkar sir, my friend Dr. Mahesh Moite, And our teacher, even if he's our contemporary, Dr. Rajesh Chokhani sir, we have learnt the approach uh, from Amdekar sir and Chokhani sir. And what is most important is that they have imbibed the thought process, not only the approach, the thought process. And what is differentiate other teachers from Amdekar sir from other teachers is they stimulate the thought process. And as Dr. Mahesh Moite sir has said that this program, Case Challenge, has reached to acme and will remain there and gain the newer heights in attendance and quality of Maha Case Challenge. So this is the big tree probably will being formed by the seeds sown by Amdekar sir. And we will like to do some justice in finding out how should be the approach. And I think it will be the peer learning here. So I wish all the best to all the participants. And as Dr. Mohite has said, that we are not taking pride in diagnosing the case or having a out of box diagnosis. It is the approach, and it has been taught for last 20-30 years how we should come to the diagnosis on history. Again, the diagnosis which will be there, what will be the anatomical side, what is pathology, what is more likely to be etiology, and what will be the functional diagnosis. If we come to this, and whatever investigations are there which will help us in confirming our diagnosis, or at the most ruling or second or third differential diagnosis. So I wish all the best, and I thank Maha IAP for inviting me to be expert, and I will try my best to give the justice for your invitation and the honor given to me. Thank you, Ingrid madam.
Thank you so much, sir. Now we will proceed to the main session, and for that I will hand over the proceedings to Dr. Shilpa Nambiar. Over to you, Shilpa.
Good evening to all the dear seniors and friends. So this is our sixth session of case-based challenges, and we are delighted to have our enthusiastic teams and moderators. I would like to first introduce our moderators. First moderator is Dr. Anand Deshpande sir, who is a consultant working in Dinanath Mangeshkar Hospital, Pune, and he is a postgraduate teacher since last 25 years, and also has been an examiner for MD and DCH. And our second moderator is Dr. Anjali Gokarna madam. She is a senior pediatrician practicing in Vikas Children's Hospital, Vasai. Our teams today are from Mumbai and Nagpur. From Mumbai, we have with us Dr. Vinay Kumar Mishra sir, Dr. Nilesh Salva sir, and Dr. Rajesh Khasla sir. And from Nagpur, we have Dr. Sadullah Khwaja sir, Dr. Ashish Lothe sir, and Dr. Abhijit Chaudhary sir. So before we start, I'll quickly go through the rules. So each team will be given only 25 minutes for the case presentation and discussion, and next 5 minutes will be given for expert comments. And then another 5 minutes for if there are any questions from the audience. Only the team member whom the case is presented to is supposed to be on unmute. Rest everybody please be on mute. And no posting any answers on the chat box. So with this, first I will like to introduce our first moderator, Dr. Anand Deshpande sir. Can you please unmute, share your presentation and unmute? And sir will be presenting his case to Mumbai team. That is Dr. Vinay Kumar sir, Dr. Rajesh Khasla sir, and Nilesh Salva sir.
Okay. I'll share my screen. First of all, I would like to thank Maha IAP for giving me this opportunity, and yourself for being behind me to get involved and do the preparation and the case presentation. Thank you, everybody, for giving me this opportunity. I'll start sharing my.
All three team members are there, Madam Shilpa of Mumbai. Are you able to see Dr. Vinay, Dr.
Yes, I am
Rajesh,
there, sir.
Dr. Rajesh, I will.
Yes.
Third, Dr. Nilesh.
I think apart from panelist and presenter, let all of us mute ourselves.
Yeah.
It will be need to at least mute ourselves, audio, video, both.
The screen is seen.
Not yet, sir.
Yes, your sharing the screen is seen.
पल्लवी मॅडम गाईड करा देशपांडे सरांना गेल्या
नाही मगाशी आम्ही केलं होतं पण
हो
आता
हो नाही हो येस पल्लवी मॅडम प्लीज
आता काहीतरी परत गोंधळ होतोय.
हे मिनिमाइज करा
हे मिनिमाइज करू आणि
यू आर शेअरिंग द स्क्रीन. पल्लवी मॅडम आहात तुम्ही? हा हे पण मिनिमाइज करा. हा आता प्रेझेंटेशन क्लिक करा आता. हा आता प्रेझेंटेशनला दुसरं तो आहे ना स्टार्ट होऊन जाईल ते दिसतंय तुमचं प्रेझेंटेशन बट हा तो दो विंडो बंद करा. हा झूमचा विंडो मिनिमाइज करा.
बंद नका करू सर, मिनिमाइज करा.
कुठली
झूमची विंडो मिनिमाइज करा सर, म्हणजे प्रेझेंटेशन फुल स्क्रीन होईल.
नाही
महा एपी ची विंडो मोठी करा फक्त
मोठी करा फक्त, त्याला फुल स्क्रीन करा सर महा एपी ला.
ओके
हा बस झालं सर, झालं. येस ओके.
Are you able to hear me?
yes sir.
And all the three participants are sitting together or they're sitting separately?
No, sir, separately.
They are
Okay.
sitting separately, but yet I am not able to see Dr. Nilesh.
Okay, right now there are two people.
Sir has joined, I think. Just now, sir has joined.
So, good evening, everybody. This is a real case, and in the wards, and nothing has been changed in the case. The time period is somewhere around last October 21. That time the case came to us. So let us begin with the case. This is a 9-year-old female admitted with a complaint of fever since 1 month. She was in some district at district place and was referred from the district place after about 2 admissions in the local 2 different hospitals locally, and then fever was not still controlled, and that's why she was referred to us. Fever since 1 month, myalgia and body ache on and off since 1 month, rash since 1 day. This was the presenting feature. HOPI. Fever was an insidious onset, 1 to 2 spikes per day, associated with chills, high grade, undocumented, intermittent in nature, relieved with paracetamol, and no diurnal variation. Rash just started erythematous maculopapular blanching rash, first appeared on the face and then spread to the trunk and extremity. This was about, everything was going on for 1 month. In between, there were periods of about 3 or 4 days or 5 days of absence of fever after some treatment in between. No complaint of joint pain, vomiting, abdominal pain, altered sensorium, headache, conjunctivitis. No history of COVID infection, which obvious COVID infection, subclinical may be there, or recent or past. What is your thinking after this? Hello?
Hello.
What are your thoughts? Thought process after 1 month of fever with 2 admissions.
So 9-year-old female with fever of 1 month. So a chronic fever, a long duration fever, not documented Sir, one thing I would like to understand, what was the fever like when the child was admitted?
Around 101, 102 in that range.
Okay, so
Moderate.
documentation of fever was there for that.
Yes, it was there. Earlier also
so-
she was admitted with the hospitals only.
So why was she discharged while on fever, or how was she cured completely before?
No, she was not cured in spite of that. We'll come to know as we progress. In spite of employing the whatever therapies or whatever treatment they gave, she had a disappearance of fever for a few days, and again it appeared, and that's why no obvious cause was found. That's why I referred for the higher center.
Okay, so she was not completely cured, but was referred to higher center for further management.
Yes.
Sir,
Completely
rash character.
Also, there was no working diagnosis, or there was no diagnosis, concrete diagnosis in their hand.
So fever without focus for further management.
Yes.
Okay. So, sir, what was the characteristic of the rash?
As described earlier. Shall I show it again back?
No, I just want
It
to
was a
understand whether
one day duration. It was
only one day duration.
One day duration.
It did not
before-
continue, did not recur,
It was not there earlier.
and did not recur after like this 1 month fever. The rash was recurring, coming and going, or it was like waxing.
No.
Just
Rash
1 day of rash.
1 day of
Okay. So this is a fever without focus. Would like to know a few things like, was there any COX contact? Is there any family history of immunological disorders? All those things we would like to know.
Okay, there was no COX contact. We'll go in further details. Any other thought process?
Sir,
You
a
want to
9-year-old
thought-
female,
What you-
9-year-old
What
female
will
with
you rule
prolonged.
out at this stage after 1 month period? By thought process, what will not be there?
Sir, acute infections are probably ruled out because of 1 month insidious onset, long duration fever.
So dengue and all that.
Yes.
Short-lasting diseases.
Acute viral exanthems. Then because there was rash as well. So acute viral exanthems. Then your most seasonal flus would be ruled out. Your dengues, malarias might, because she was twice admitted for fever, must have been ruled out. So those things gone. From here, I would start thinking of chronic fevers. So first would be a tuberculosis.
Okay.
And second, because a female child and of 9-year-old, will start thinking of autoimmune disorders as well.
Okay. We'll progress further.
Yes.
Sir,
Can I? Yeah.
Anybody you want to add anything?
Yeah, I'm Dr. Savla, Dr. Nilesh Savla from Mumbai. Sorry for joining late. I heard the case history. Just I would like to know, the rash came on which day of fever? Was it came after the admission?
After one, when she came at 1 month of fever to us. 1 day prior to that, there was a rash. So it was not accompanying throughout.
Not throughout, accompanying throughout. Yeah, and any details of the treatment given during the admission?
That we are going to come. We have prepared the slides for that. We'll come to know.
Yeah, so for in my view, this is like an intermittent fever in a 10-year-old child, which is coming and going, for which she was admitted twice. So now either it could be a recurrent viral fever, maybe high fever, or it could be malaria. Secondly, it could be malarial fever, which is getting treated and not getting treated adequately, or she's getting infected again and again, or as Dr. Mishra said, that as she's a 10-year-old girl and there is fever intermittent, she could be going on for some multi-systemic disorders like autoimmune disease also. And this age to consider for urinary tract infection less likely. Infant or 2-year-old child, I would consider UTI also as a cause of recurrent fever. And one more cause is like acute tonsillitis can come like this. You have fever, you treat, it gets better, and sometimes the foci are not gone completely. You can have recurrent fever, it may be less likely, but one has to consider that also.
There will be some localized soreness in the throat or some localized there.
okay.
Let's proceed.
Can I? Yeah. Can I, sir?
Yes.
Yes. So my view over here is that this is a generalized problem. The complaints are fever, myalgia, body ache, etc. So it is some generalized infection. There is no localization of this. And second thing is that rash has come up quite late in the illness. So this is a fever of unknown origin, which is going on beyond 2 or 3 weeks. And more the duration of fever, less likely to be an infectious fever, more likely to be a non-infectious etiology. And there is no localization, no anatomic localization.
So according to you, at 1 month, there is no infection? If there is a 1 month fever, you should not diagnose infection?
The chances of infection would be lesser. It will be more of non-infectious, either some autoimmune or maybe a drug rash also. We would like to know what drugs, etc., was given to the child in the past.
Okay.
So my diagnosis here, excluding all the common viral and bacterial plus malaria, dengue infections, would be chronic infections versus autoimmune.
Okay.
Yeah, one has to consider tuberculosis here. You cannot rule out tuberculosis without investigations.
Yes. Let's proceed further. We have thought this. You have given your inputs. It was found out there where they were residing nearby a cattle shed. The cattle shed, Gotha. Gotha was very close to, as if they were residing in the Gotha. There was no history of consumption of raw milk, drug allergy, or contaminated logged water. Recent treatment history, child was admitted with above complaints in the peripheral hospital and workup was done. Received treatment outside, IV vancomycin meropenem for 5 days, IV methylprednisolone for 5 days. These are actual things. Huh? There is nothing bada chada ke kuch nahi hai. With probably they must have had, it was not written anywhere on the paper, but probably they must have thought of Miss C, because those were the days of Miss C. And IV methylprednisolone for 5 days. Initial response followed by persistence of fever and no subsequent clinical improvement, hence referred for further evaluation and management. Any take on the vancomycin and meropenem?
Sir, I would.
Right thing.
Sir, rash was after giving vancomycin or was it before?
Maybe because the time sequence I don't remember right now, because it's about 6 months back, but it was just before coming to the hospital.
Okay.
But
so
if
it was not,
we have to comment whether IV vancomycin or meropenem should have been given or not.
Too high, sir, too high. I mean, to start with meropenem and vancomycin, you are trying to cover just about everything and not treating anything.
Okay. These are the various labs on various places. She went to 2 hospitals. We have made a tabulated form. So this is 211 lab was probably reacted to and was methylprednisolone and everything was given, because she had a D dimer of high D dimer. Then ferritin was also high. COVID antibody was positive, and that's why she was that antibiotic plus that methylprednisolone must have been given. So, any take on this COVID antibody positivity? Your opinions?
Sir, can I?
Yes.
I totally disagree to the diagnosis of Miss C, because when this case is presented and the COVID antibody positive, by that time most of the patients or most of the children would have got infected, and most of them are going to be antibody positive. Second thing is, clinically, sir, there was no history suggestive which was pointing towards Miss C, because the child had just come with fever and body ache. There were no other symptoms, no conjunctival, no mucocutaneous involvement. And there are no documented those criteria which are laid down for the diagnosis of Miss C.
Yes.
So I totally disagree with the diagnosis.
Absolutely correct. Absolutely correct. And this is the message we want to circulate, because now anybody you test, you have a COVID antibody positive, and there is over-labeling of Miss C going on. So this is a very valid point you have mentioned.
Another thing, just on the basis of an elevated D dimer, it doesn't warrant us to give methylprednisolone in the dose also that has been mentioned.
Yes. The indication of methylprednisolone in Miss C are very specific, and basically this was not Miss C.
Yes, this was
mislabeled Miss C.
Yes.
Luckily, IVIG was not prescribed, which would have cost a bomb.
So this is the lab on very different days. 6/11 was the last lab done outside, and was referred to us on 7/11. So just have a look, or if you want, you can come back to the lab again. There is a neutrophilic predominance all the while, except after giving methylprednisolone, last one. And
there is progressing falling
TRP
counts.
is consistently high, except after giving methylprednisolone again.
And the total counts are persistently coming down. So the total counts
from earlier higher, but later on they were less.
progressively decreasing.
Yes.
And going towards lymphocyte predominance.
Let's go further. What do you think are the possibilities now with this history in your hand, with a history of a cow shed, or they were living near the cow shed?
Sir, when there is clear-cut history of no consumption of raw animal milk, but there is a history of living near a cow shed. In that context, brucellosis, which can be one of my, which when I said chronic infections would be in one of the causes. So brucellosis might be.
So do you mean that you can have a brucella without consumption of raw milk, just by being close to the animals?
Could be, sir. I'm not saying it is like, a lot of people drink raw unpasteurized milk as well, but all of them are not wounded brucella. So that's where I'm saying it, living near a cow shed, as you said, means right in the cow shed. Could be close contact with animals.
That history I did when the patient came in the ER. I took the history. They told us they were just living in the next to cow shed.
Can I talk? Can I interfere? See, cow shed, living cow shed is too many very common thing. In villages and in some places, there are a lot of people who live besides cow shed.
Yes.
So that may not tell us much. Now here I would like more investigations in the form of like
that you are going to come just after this initial investigations. I'm asking again. Further what we did, we are going to show again.
So the differential remains same for me. The differentials remain the same. Like you have to investigate for tuberculosis here first, because it's a chronic fever, TB being so common, and at the same time, of course, investigate for other conditions like as we discussed, the collagen vascular disorders or other fevers.
Okay.
Sir, I would just like to understand before going to the investigations, any positive finding in examination?
That I'm going to show next slide. Is that okay?
Yes.
Yes,
this is how many days of fever, sir? Just to ask now, how many days of fever?
1 month fever. When she came to me, it was 1 month fever.
1 month. So rarely we have to consider even the typhoid also, which is not treated, adequately.
Or partially treated.
Partially treated typhoid, because vancomycin, meropenem was given only 5 days, which are not the right drugs for enteric fever. So even we have to consider the enteric fever also ongoing. Of course, not very high on the list. But
or you can say, sir, 5 days of meropenem is a sensitive antibiotic, but less adequate. The duration is not completed.
On the top of it, methylprednisolone was
suppressed everything.
Yes, correct.
So clinical findings on admission: febrile 100.4, flushed appearance, pulse rates 126, RR 20, SpO2 98, BP 110/68, pallor plus, tender cervical lymphadenopathy, no icterus, cyanosis, clubbing, edema. Systemic examination, significant findings. Abdomen, tender hepatomegaly present. Right upper quadrant tenderness present. It was soft. Bowel sounds present. Spleen not palpable. Respiratory air entry, breath sounds clear. CNS, normal sensorium, higher functions intact, no neck stiffness, signs of meningeal irritation, normal motor, no neck stiffness sign and signs of meningeal irritation, normal motor, sensory, and cranial nerve examination. CVS S1, S2 present, no mount. Now, any short listing?
Sir, as I said, we have to again consider enteric fever because there is tender hepatomegaly, and also consider other liver conditions like say liver abscess.
But there is no spleen. There is no spleen.
You may not be able to palpate.
One month of fever.
Still, because it depends on sometimes on the examiner also. So you cannot go only just because spleen is not palpable, you can rule out typhoid fever. So I would still consider enteric and liver is tender. I would also like to consider liver abscesses in the differential diagnosis.
Liver abscess is what is liver abscess is one of the valid differential.
Yeah.
So prolonged fever, hepatomegaly, and
Absence
cervical
of spleen. If you take that the spleen as absent, and there is no error of the examiner, suppose, then the spleen is absent. What things will go out from your differential diagnosis?
Malaria would, because 1 month of fever with no spleen, malaria would be, I mean, clinically at least malaria would be out.
Even enteric would be also out.
Enteric maybe, and other conditions like say leukemias or
Brucella.
malignancies.
Brucella.
Maybe Brucella also could be out.
So lymphadenopathy is there.
Single lymphadenopathy is there. Tender.
Significant tender lymph node.
Single, but there is no generalized lymphadenopathy. Okay.
This is
what
this lymphadenopathy.
So still what things remain, whatever we had discussed earlier, what remains in the line now? We discussed about tuberculosis, you said.
Yeah, COX definitely
still inside in the process, in our thinking process. Can it
so
be
now what the problem is with methylprednisolone, lot of the symptoms of COX might have been masked. Full course of methylprednisolone.
What about the myeloproliferative disorder?
So that's what I said, that spleen is not palpable, so less likely,
And
less likely.
Yeah.
Again,
you cannot rule out, but less likely. Yeah.
Okay. Any hepatic tumor?
Hepatic tumor, yeah.
Is giving rise to fever at this age? Not unheard of.
Not hepatoma doesn't. I mean, 9-year-old might not have hepatoma. So I mean, age is a little.
And hepatoblastoma will come quite earlier.
Quite early, yes.
So that is out of question. That will have some chronic fever, may have.
So it again boils down to probably a chronic infection versus an autoimmune disorder.
Okay. Let's move further.
Yes, sir.
So on day 1, started on symptomatic medication only. Now, what happened at our place? So relevant workup was sent, which was as follows: CBC 9.6, TLC 10,418, neutrophil 78, lymphocyte 18, platelets 3.91, PCV 30, and MCV 69, MCH 21, CRP 74, sodium 131, potassium 3.8, chloride 97. Liver function test, total bilirubin 0.76, direct bilirubin 0.45, SGOT 67, SGPT 131. There is a rise in the SGPT. Alkaline phosphate is 254. Then total protein 6.1, albumin 3.29, renal function test urea 27, creatinine 0.45, calcium 7.9, phosphate 4.03, uric acid 3.42, urine routine normal, X-ray chest normal. USG abdomen shows liver enlarged and measures 13.8 centimeter, normal texture, hepatic veins and portal veins are normal. Gallbladder is partially distended. Walls are mildly edematous. Both kidneys are normal in size and texture. Spleen is normal in size and texture. Visualized bowel loop shows normal caliber and peristalsis. No evidence of lymphadenopathy. Mild ascites is seen. Impression, mild hepatomegaly, mild gallbladder wall edema, and mild ascites. So this is about USG. Then this is about 2D echo findings. Coronaries are normal in size and echo texture. No vegetation seen. Impression normal heart study. Now again with this we have supplied a lot of data to you. So what is the diagnosis? Or any other investigations you want? You want any other investigations?
The blood culture was attempted any time before?
Yes,
or
negative. Before must not have been done.
Okay.
But we did blood culture, urine culture, and it was there was no growth after 5 days.
So it was not a gross ascites, so there was
no minimal ascites.
Yeah, so tapping or anything.
It was not clinically detectable ascites.
Okay. Okay.
Sorry to interrupt, but we have only 5 minutes.
Yes, we'll finish off faster. So again, differentials. Absence of spleen rules out many things. Hello?
Yeah. Yes, sir. Sir,
So-
now again we have to consider other diagnoses also.
So any other investigation you want from our side?
Sir, Vidal, of course, of not that much useful. But Vidal, if it is done, we can check on that.
No, Vidal nowadays people don't do, and an absence of spleen. We have
Any
not
other-
done Vidal. We have not done Vidal.
By the 4th week, if the urine culture is also negative.
Any progression of the disease after admission here? Any rash?
There
Any
was
arthralgia or spine problems, spine issues?
yes, we'll provide that. We'll provide that. Any other investigations you want?
Oh, we can do X-ray chest and MT, sir. Mantoux test and X-ray chest.
X-ray
X-ray was normal.
Mantoux.
Let's go. We have less time, so let's fast forward because there is one more case.
Okay, sir.
So we are now so we are now stuck because there is a only hepatomegaly with some changes in the liver function test. That is a positive thing here. One more symptoms. Initial diagnosis pyrexia of unknown origin was made. Brucella antibodies, blood culture, urine culture, tropical fever panel also was sent from us. We have a PCR, tropical fever PCR, and that is quite reliable. That also came negative. Child was started on oral doxycycline residing nearby cattle shed for PO empirically till we had the diagnosis. That we asked this question. Child was specifically high grade fever, 5 and rash and was vitally and hemodynamically stable. Okay. now we have to think about the rheumatological causes. On day 3, what happened? Patient developed mild pain in the MP joint, metatarsophalangeal joints. And the rheumatological reference was done. So what test you would like to order for rheumatological?
ANA would be the first.
ANA, which type of ANA you would like to send? ANA, there are various methods of sending ANA. Are you conversant with them?
No, not so.
There are ANA by ANA as it is normally present positive in about 10% of the 10% of the population, and ANA or any rheumatological investigation needs to be interpreted looking at the patient. Its concentration, that is 1 in 40, 1 in 80, or 1 in 320, that is more important than the just mere presence of ANA. So that is before sending ANA, one should know that 1 in 40 ANA the dilution doesn't mean anything, and it may be present in about 10% of the normal population. As the strength of dilution goes on increasing, that means that it is strongly positive, then the chances of it being accidentally positive is less. So ANA by blot and immunofluorescence studies was done. In rheumatological, initially we thought of what SOGIA.
GIA.
SOGIA is one of the, but again, lack of spleen
Yeah.
will go, SOGIA will not fit into that. Lack of spleen, lack of rash coming so late. So we sent C3, C4 levels along with CPK, added naproxen for the pyrexia, and this was the report of the ANA by blot. ANA by blot comes, there are several subtypes of ANA, and according to the pattern, you can diagnose the disease. These are the various patterns. So this pattern of our patient was fitting into Sjogren's or Sjogren's syndrome. This is anti-SSA rho 52 and anti-SSB antibodies present that fits into Sjogren's syndrome. So these are the various patterns. By these patterns, you can recognize or diagnose the disease by sending ANA by blot.
Yes, sir.
So ANA by AFA, IFA was also done. Positive for it shows, it doesn't show the subtypes immunofluorescence, but it gives you confirmed positivity. And immunofluorescence pattern observed was nuclear speckled, endpoint titer was 1 in 320, suspected antigen specific SM, HMRNP, and SSA and SSB. Follow-up testing ANA by immunoblot and ELISA sensitivity for above mentioned antigen was advised. So working diagnosis was taken as a juvenile Sjogren syndrome. Dermatology review was done, who advised ophthalmological review for dryness. Start oral prednisolone 0.5 mg per kg per day and tablet SCQS 200 milligram OD. And ophthalmologist review was done. Both eyes are dry, with right more than the left. There is test done for the dryness of eye. It was positive. No corneal haziness, synblepharon, follicular conjunctivitis, bilateral fundus normal. Impression, eye, sicca. There is a dryness, dry eye. Follow-up, child symptomatically improved. MCP joint pain and stiffness decreased and was afebrile for more than 48 hours with improvement in activity and intake. Child had a good response to oral steroid and was discharged on the oral prednisolone and SCQS and advised regular follow-up. Final diagnosis, juvenile Sjogren's syndrome. This is how it presents. And there is a systemic, it generally begins with the gland, but sometimes it can have a systemic symptoms like this. Most of the patient will come with the glands, with parotid swelling or like that. But sometimes in children, they can have, this is a hepatic form of a Sjogren. This is a chronic inflammatory autoimmune disease characterized by the progressive lymphocytic and plasma cell infiltration of the exocrine gland, especially salivary and lacrimal, with potential for systemic manifestation. It is rare in children and predominantly affects middle-aged women with the classic symptoms of dry eyes and dry mouth. The mean age of the diagnosis in children is between 9 to 10 years, and 75% are girls. These are the criteria for diagnosing. For short of time, will not enter into that. Thank you. You were right from the beginning. You were on the right line. You were one of your diagnosis was autoimmune. So your thinking process was on this same line. Thank you. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.
Nice case.
Thanks.
Thank you, sir. That was a really good case and good approach by Team Mumbai. So that's hats off. And I would like Dr. Ramakant Patil, sir, to add on a few words.
Shall I stop sharing?
Yes, sir, you can stop sharing.
I will like to congratulate all the team participants and Dr. Anand for presenting a wonderful case. Where most important, as the teaching goes by Amdekar sir, is that in any fever of 1 month or beyond 2 weeks, we have to have timeline of the fever is very important. And whenever you are stuck in fever case, what I expected from the participant is, what is the, basically they have to go into details. Many of them try to, 1 or 2 persons did try to take out the history of fever. So first 4 days of fever is very important. How was the fever? Whether it was rhythmicity of the fever and onset of the fever. And after that, on day 3, day fever, what had happened? In rhythmicity, if it is initially very high grade fever, and on day 3, day 4 become better, it was a viral. If it is worse, it is more likely to be bacterial. If it is same, the very fact that this patient had come on after 1 month of history, so it has gone to the timeline of fever after 2 weeks or 3 weeks, and very few conditions remain over here. If at all it is infective, it will be only tuberculosis, it will be brucellosis, and some viral infections like infectious mononucleosis. In case of infectious mononucleosis, what we commonly find is that these are the patients who are getting recent onset snoring. These are the children who are playful. Most of the time, as Anand has said, they do have splenomegaly. But this was one of the important. Again, in timeline of fever, if the infective cases are ruled out and these patients with fever after 2 to 3 weeks, we have to consider, since this patient was having same clinical condition. So either it was a slow growing malignancy or immune mediated or non-inflammatory disorders. So here cervical lymphadenopathy was there. Patient probably had some mouth lesions. Here important 9-year-old girl in pattern of rheumatological diseases. Mouth ulcer is one of the important. It should not be attributed to some vitamin deficiencies or sickness for so many days. It will definitely point you to the some immune mediated diseases, particularly SLE. Echocardiography was done. It is one of the important cause of fever, infective fever after 2 weeks, 3 weeks, because of poor localization. So any fever lasting for 3 to 4 months remaining same, we have to find out the infections with poor localizing like tuberculosis, brucellosis, infectious mononucleosis, infective endocarditis. At the same time, we have to keep in mind the inflammatory disorder or immune mediated disorder, which was rightly done over here. And most important thing is that previously we used to say that any fever is not deficiency of, say, trioxane, But now they have gone in upper league and higher echelons. Now they feel that any deficiency of vancomycin is the cause of fever. So it is not the deficiency of ceftriaxone or vancomycin meropenem, and over and above that, the methylprednisolone. So it is not the deficiency of ceftriaxone or vancomycin or methylprednisolone. So most important here is again timeline of fever and day. How was the fever on day 3 and day 4? Rhythmicity and associated symptoms. And this has to be approached, and that probably it would have given us the diagnosis over here that if there is no recent onset of this thing, snoring, infectious mononucleosis is ruled out. If there is no patient is not deteriorating, then your rickettsial and other things are ruled out. If there is no contact history of tuberculosis, it will go down in the list. So considering this and lymphadenopathy and the rash, so pattern of fever is very important. So on clinical history only, probably we were heading towards immune mediated, most likely immunological disorder, hematological disorders. So this is very important. We should take home the message that timeline of fever is very important. Detailed evaluation of fever is very important. And fever is not the deficiency of ceftriaxone, vancomycin, meropenem, or methylprednisolone. I congratulate Anand and all the team participants. And thank you, Maha IP, for giving me, and Mahesh Moite sir for giving me an opportunity to opine. I think Dr. Chokhani sir will and Dr. Mahesh Moite will add on to this. So if you have time, we'll do this, or otherwise we'll proceed for the next case.
We'll do at the end, I suppose. Let's go for the second case.
Okay, so without wasting any time, we'll start the second case and we'll come back to this one later on. So for our second case, I invite Dr. Anjali Gopan ma'am to please start sharing your presentation. And team from Nagpur, that is Sadhurna Khan Khwaja sir and Dr. Abhijit Chaudhary sir. Dr. Ashish Lote sir is not reachable. I tried, but and he's not there. So let's proceed with.
Can I start, Shilpa?
Yes, ma'am. You start.
Yeah, so very good evening, and thank you to Maha AP for giving this wonderful opportunity. I must also thank Mahesh for goading me on into this case. And until the last minute, I felt there were so many things to be done, but finally they have been done. And a warm good evening to all the dignitaries on the dais and Dr. Ramakant Patil sir. This 20-month-old child came to us about 3 months ago with swelling all over the body since 5 days. He had loose motions for about 5 days, which was small and semi-solid, no blood or mucus. He had cough since 2 to 3 days, which was also mild. Parents noticed that he was sleeping a little more than usual since 2 days. They felt that the puffiness of face began suddenly since the last 5 days. There was no diurnal variation which they had noticed. They had gone to some local doctor for the symptoms, and he had started some antibiotics as well as omnacotil. So from this slide, would the team members like to opine something? This child came with generalized puffiness of the body.
Yeah. Ma'am, hi, good evening. So this is a 1 year, 8 months old child.
Yeah.
And with a history of swelling all over the body since 5 days, with appearance of swelling first on the face. Probably my thought process initially goes towards maybe he has deficiency of protein, albumin urea is there, because of which, and there is some kidney.
You have got muted, Dr. Abhijit, and there is a lot of disturbance. So can I request everyone to mute themselves? Yeah. Yeah, Dr. Abhijit.
Yeah. So, ma'am, the first thing which comes to my mind seeing this slide is that probably we are dealing with some kidney disease. There is a proteinuria, and because of which the swelling first appeared on the face. The loose motions per se can be seen in such kind of conditions. There is no fever, so less likely an
No,
infection.
I have not completed the history. So
Yeah.
only on this much history, you have thought that this could be a kidney. And would anybody else from your team like to opine and any other opinion?
Hello, I'm Dr. Sadullah Fajana. Am I
Yeah,
audible?
Dr. Sadullah. Yeah.
This is a 1 year, 8 month old child with swelling over the body. So, considering this to be edema, we have to consider which organ system is causing this edema. So, in this case, kidney is most likely to be causing this edema since there is periorbital copiness. And this would be too early to say, but as a differential from this much information,
Yeah.
there can be AKI secondary to dehydration. I could also think of HUS, but it is quite early to say. There can be celiac disease because of there can be albumin loss in celiac disease and leading to edema of periorbital. So
Excellent. So you thought of a renal disease and you thought of gut losses of proteins. So that's nice. And would you like to know more? So I can tell you more. This child had no fever, no vomiting, no abdominal pain or discomfort. He had no urinary complaints. He had never had any breathlessness and he never had any skin rash. He was never ill prior to this. It is a non-consanguineous marriage. He's a second child and there is no family history. You want to know anything more in history?
Ma'am, even the urine output is normal, means no
Yes.
urinary complaints.
Yes. This child had a decreased appetite since 2 to 3 days since the edema began. So he was eating less and drinking less. So there was a little decrease in urine. But that
Okay.
was only
was
no
there any
hematuria?
no hematuria. Yeah. No urinary, no burning, no other urinary complaints.
Okay.
You
And
want
was there any history of recent weight loss or
no, not
child
by
is
the
not
parents.
coping up with not coping up with fears of pain like that?
Intellect, cognizance wise. No, there was nothing of that. This child was absolutely okay according to parents until 5 days ago. And anything else you want to know in history?
Was he admitted anywhere else, ma'am?
No, never. He has never been ill. Should I go to findings or you want to know anything more in history?
Can proceed to findings.
Okay. I'll give you one very important history. This child was only on a predominantly milk diet. This child used to drink 1 liter of milk by bottle every day, which gave him 650 calories and 20 grams of protein roughly. And this child was so irritable that he demanded chips, colas, and biscuits, and the parents always thought. So his caloric intake was met with all this. And occasionally he would eat from family meals. Although he loved it, his parents thought milk was his primary diet. Any thoughts on this?
Yeah, definitely there is a calorie and protein deficiency, and not only that, there will be other micronutrient deficiencies.
Yeah, excellent, Dr. Abhijit. You used the right word, which I would have loved to use. And so this child actually didn't fall short in calories because he made up all his calories by eating cookies and colas. And even milk would meet some of his caloric requirement, and his protein requirement was quite good. So his intake of proteins was good. And on examination, he was pale, irritable. There was anasaka. There was no icterus. His skin was absolutely normal and his chest was normal. His CNS seemed okay. He was very drowsy and he wanted to sleep most of the times, but otherwise his CNS was normal. Any other thing you would like to know?
Any knuckle hyperpigmentation?
No, there was no knuckle hyperpigmentation, but his nails in the lower limbs were platinikia.
Okay, platinikia.
So, Dr. Sadullah, you have muted yourself, so I can't hear.
Ma'am, was there any organomegaly or lymphadenopathy on
Yeah, so
examination?
I'm coming to that. There was a liver which was 2 centimeters soft, and there was ascites, abdominal distension. There was no spleen palpable. There were no lymph nodes palpable.
Ma'am, no clubbing?
No clubbing, no cyanosis. His respiration was normal, and he was a hemodynamically stable child. His blood pressure was normal.
This liver 2 centimeter, I hope the span is okay. So probably we are not dealing
Yes.
with.
No, the span was okay and the liver was soft.
Ma'am, this is seems to be can be a case of encephalopathy. So, was there any other CNS findings like any abnormality in DTRs or planters or anything like that?
No, the CNS examination, except for drowsiness and irritability, he was otherwise okay. There was no local signs. There was no signs of hypertonia or an upgoing plantar. Okay. Now, these were all the physical findings. There were no meningeal signs as well. And anything else you'd like to know, or you'd like to go for something?
Ma'am, what I can make out in the clinical database is that probably he just had a edema with a predominantly milk-based diet with no organomegaly and just a irritable child, no other CNS manifestations. So probably somehow this is leading towards more of a some nutrient deficiency, because that diet, he was milk-based diet, though calorie proteins he was able to make, but we don't know about the other nutrients, whether he was getting or not.
And he was pale and puffy.
Yeah, pale and puffy. Exactly.
Yeah. Okay. So do you think there are two diagnoses, that the pallor and the milk is something else and the edema is something else?
Yeah, it could be, means he definitely would have iron or B12 deficiency, and now the protein loss, either it is from the gut, kidney seems less likely based on clinical history, uh, maybe from the gut.
Okay, great. Yeah. So you're coming very close to it, and this was his height and weight chart. He was 50th percentile for both height and weight. Any comment on that?
Somehow this suggests that this is not a chronic process. Probably it could be an acute one. This is only I could make out, but we should know the velocities, how it was previously. It's just a one chart, so difficult to comment, but still it's a good growth.
And the parents were of average height and weight. Would you make allowances for the edema?
Yeah, agreed.
Yeah. So we would make some allowance for the edema, and this was his growth chart. This was one of the very important findings that was there. Anything else you would like to know? So this was the first investigation we did. Any comments, Sadullah? And where's your third member?
The HB 7.5 and the other two parameters like MCG and MCH both are on the lower side. Considering the PS, this can be there are microcytes, hypochondria, suggestive of iron deficiency, anisocytosis. So iron deficiency. The overall the case seems to be some acute insult in a child who was having normal growth till now. So I would like to further have more investigation.
Okay, so the acute illness, you mean to say whatever he had, that rotavirus or whatever loose motions was the thing that was the acute illness, and somehow you think that could have caused the edema?
Yes, ma'am. Acute.
Okay, and we need to do further tests, like you said initially.
Yes, further investigation.
Do we have a RDW here?
RDW, I think was there, and it was normal. Yeah, we do have RDW was high.
Just want to add, ma'am,
Yeah.
the loose stools which was mentioned in the history was just 4 to 5 episodes per day, and they were semi-solid.
Yes.
So probably I feel that is not contributing to this picture. let's see, but we will go see the other investigations and we can comment more.
Okay. Any comment about the RBC count in face of a low?
RBC count, yes, RBC count is quite high. Probably with a iron deficiency, I would have expected a lesser RBC count. And there is a significant microcytosis, hyperchromatosis.
Platelet count is also, there is also thrombocytosis, which is
Excellent. Excellent observation. Yeah. So the WBC count as well as the platelet counts are on the higher side. The HB is on the lower side, which goes in favor of iron deficiency anemia. But the RBC count is not in keeping with that. Something crossing your mind when RBC count is not in keeping with the low hemoglobin?
Yeah, it would be some. Yeah.
Dehydration can lead to.
Dr. Abhijit?
No, it could be this picture could be of thaltrate.
Okay.
Contributory.
Yeah. So you think it could be one more possibility of thaltrate and iron deficiency is there?
Yes.
Yeah. So now we have to go for the next investigation, and that's the urine test. So as you thought quite correctly initially, there was no albumin in urine, no CAS, no red blood cells. The urine was absolutely normal, which was very, very surprising for the resident doctors as well as us. And we now had to really think hard. So we did what other investigations? So we did serum proteins. Any thoughts on this?
Yeah, ma'am. There is significant hypoalbuminemia with quite good proteins and globulin. So there is definitely loss of albumin, and the kidney is not the thing. Probably there is a loss from the gut.
Is there any possibility of a hepatic? Is the manufacturing somewhere at the
serum albumin is quite low and the A by B ratio, globulin is quite high. So either they can be, there is definitely loss of serum albumin and the globulin levels are very high.
Globulin seem okay, but the albumin is severely low. So at this point in time, any thoughts on where the gut losses could be and what could be the possible reasons for the gut loss?
Protein losing enteropathies can have such picture.
Yes.
Yeah. So this is a protein losing enteropathy. Yeah, but protein losing enteropathy is a broad term for many subgroup of things. So any quick things that come to your mind?
Celiac diseases and Crohn's.
Yeah, correct. Right. So celiac disease, which is a chronic inflammatory condition of the gut. You can have Crohn's, which is also chronic inflammatory, or ulcerative colitis would not cause loss of albumin. Yeah. Any other cause, even acute CMV or rotavirus can cause a loss of proteins from the gut. Any other primary gut condition which can cause loss of albumin? So what about lymphangiectasis?
Yeah, that can.
Yeah, primary intestinal lymphangiectasis can cause. So these are some of the thoughts when there are loss from the gut. Any other investigations you'd like to do? So so far, things you have thought of?
From initial presentation of acute symptoms, and I was considering the edema was because when I didn't have had investigations, I was considering it to be of renal origin. So I was thinking of history of dysentery and then sudden renal failure. It can be because of HUS, which in
but
HUS
this child was.
Yes.
Yeah, but then, this was hemodynamically stable. So this is not a very not a very hemodynamically acute disease.
Then there was history of predominant milk consumption. So cow milk protein allergy was also one of my.
Excellent.
Then as a considering other investigations and this seems to be more likely to be
Yeah.
protein losing enteropathy spectrum of disorder, as you said.
Correct. So we are thinking of iron deficiency, we are thinking of protein losing enteropathy, we are thinking of possibility of a thal minor, and we are also, what other thought you had in your mind? You thought of cow milk allergy. Excellent. So these are some of the things that are possible in this child. Yeah. So the next investigation, would you like to do iron studies?
Yes, ma'am.
Yeah. So what does this show?
So low serum iron.
Yeah.
With a high binding capacity. And transfer in saturation 4%. So we are dealing with iron deficiency, definitely.
Severe iron deficiency.
Severe iron deficiency.
Correct. So we did, would you like to do HB electrophoresis? Because we thought of thal minor.
Yeah.
Yeah. So how would you read this? The fetal hemoglobin is 0.7.
Normal, ma'am.
Yeah. Is this normal? Yeah.
Yeah.
What would be your comment on HbA2?
So usually if it's more than 3, we consider the possibility of thal trait.
What about in the face of iron deficiency?
In the face of iron deficiency, it can be low. In thyroid disorders and iron deficiency, what I know, this can be falsely low.
Correct. So we would have to still keep that in mind. So iron deficiency, and we still have to think that after the iron is corrected, we may have to do this. And anything else you'd like to know for protein losing enteropathy?
Stool examination.
Yes.
Yeah. Stool examination, somehow the mother never gave us a stool sample. And in fact, till today, I'm after her to give me some samples so that I can do at least calprotectin just to complete my case workup. But she has never given us a sample. But if she had given, I would have done an alpha-1 antitrypsin level, because alpha-1 antitrypsin is a surrogate marker for albumin loss, and it does not get degraded in the stool. And also we'll do for calprotectin to see for inflammatory disorders like either Crohn's or ulcerative colitis. So, but this was not there. And so there was protein loss, but we couldn't demonstrate it, or we couldn't show it on any of the tests. So what are the diagnoses so far?
Probably we are dealing with a protein losing enteropathy with severe iron deficiency.
Correct. So do you think the iron deficiency is the cause or the effect of the protein losing enteropathy?
Probably it's the effect.
Now, how would you approach this case? Now, what would you do from here on? Now we know that there is severe iron deficiency, possibility of a thal minor, some cause a kind of protein losing enteropathy. Perhaps the commonest one we think of protein losing enteropathy as?
Celiac disease and
celiac disease. Yeah, celiac disease. That's the commonest we would think of. And also we know there is an abnormal intake of milk, very high. So here on, what would you tell the parents, and how would you manage? Because that's how we have to.
So, ma'am, we can, how we will counsel is that probably the issue is in the gut, and whatever investigations we have done, so there is some problem with the gut, and the protein is they're losing. So if we have to go for the establishment of diagnosis, one thing is that we can go for a upper GI endoscopy and biopsy.
Excellent.
Endoscopic guided biopsy should be.
Any other way of ruling out celiac disease?
Yeah, TTG plus IgA levels we can do.
Excellent. But would you get that positive in a 1 year, 8-month-old child? And is there some other test?
Usually the literature says less than 2 years, it's not possible.
And then we would do another test, which is called the deaminated glucose.
Yes.
Yeah. So gliadine peptide test, the GDP, IG, and IgG test. All these are very expensive, and the parents said, no, we are not going to do it, and we are not going to allow you to collect blood either, because we offered that we would pay for it. So now what would you do?
Is upper GI endoscopy an option?
No, that's pretty expensive too. because I come from a small setup and in a private setup, and these parents said कि वैसे तो अभी तक तो बहुत अच्छा था, अभी 5 दिन से हो गया है, why you want to do endoscopy and why do you want to go for expensive tests? So how will you proceed?
And acutely, we need to give, we need to infuse albumin for this patient since he's quite symptomatic with a very low serum albumin level. So, and
Any other thoughts?
now,
Ma'am, can we just see if we are not able to go further with the diagnostic test? Can we just stop? We just modify the gluten-free diet and
Okay,
see.
so
yes,
so
One way we can just go ahead.
that is, what all will you eliminate?
Gluten. We'll give all the gluten-free things to him.
Like
Uh,
they are predominantly North Indians, and that grandmother is very fond of milk and chapati.
Are they predominantly North Indians, ma'am?
Yeah, they are predominantly North Indians.
Okay. So we'll
So
stop.
what all? Yeah. So what all will you stop? So if in gluten free, you have to stop bread, cakes, biscuits, chapati, maida. So everything that goes with wheat and even barley and rice. So even that is out. And it's difficult to give that. So any other thoughts?
No, ma'am. I think I think this is one thing which we'll do. We'll try gluten-free diet.
Okay.
Yes, and the dietary counseling remains the only option.
Milk?
What about milk?
Milk, ma'am. The only thing is he's just fully milk-based diet. He can take milk, but probably once or twice a day.
After 1 year of age,
We also considered he could have cow. Yeah.
Milk can give only 70% of the required nutrients and calories. So we need to supplement we cannot let the child have predominantly the milk as the diet. So
okay.
We need to supplement.
Okay, so can I go ahead and say what we did? Okay, so we have anasaka, we have iron deficiency, we have protein losing enteropathy, and we have thaltrate, which all of this you have said before. I just wanted to ask you what you thought of that anasaka. It's because of low protein, because of that. So what we did is that it was very difficult to put this child on a gluten-free or a milk-free diet. So we looked up and we said, what could be having iron deficiency and protein losing? And we found to our surprise that there were a number of reports which said that protein losing enteropathy in the setting of severe iron deficiency, the iron deficiency is not the result of protein losing, but is the cause of the protein losing enteropathy. So iron deficiency somehow alters the gut, and it causes the tight junctions of the enterocytes to become loose, and it allows the passage of proteins into the gut, and it is lost. The albumin is lost through the gut, and the cause of it is severe iron deficiency. So we thought, so there's one more protein losing enteropathy in the setting of, there's a case series, and all of them, if you see, and I can give you these references, they say that these are all 20-month-old, and all of them have been taking cow's milk in very high amounts, and they don't eat much of the normal food. So that was what was the case series. So what did we do? So this is what the article said, that iron deficiency causes tight junctions of enterocytes to be defective, and the protein is lost into the lumen of the small intestine. So how did we manage? So I wrote a prescription for the grandmother. I said, you have to give dal chawal, you have to give roti sabzi, give anda, you can give chicken, mutton, you can give machi, and you can give only 300 ml of milk in the whole day. So because she is very fond of milk, I could not tell her that you can't eat. And I didn't stop the gluten totally. And that's because if you saw the growth chart, even if you make allowances for the edema, he was still on the 50th percentile. He was nowhere even near the 10th. So I thought that he has grown well despite all of this gluten. So it's unlikely to be celiac. So, And what we most of us forget to do is we write prescriptions of medicines and explain that in detail, but we take very little time to explain to parents about diet. And I thought that we should even write diet as a prescription and tell them exactly how much and how they should give that. So that's what I did. And if you see his diet, I was so shocked. I asked the sisters to note down what he was eating. When he was admitted, he was eating ice cream, and then he had chocolate, and then he had biscuits, and he had tea. And after we went on telling them what was right, by the end of the second day, you can see that he was eating dal, rice, orange, banana, half an egg. And on the third day, he ate 2 eggs. So, and also by this time, please note that we had started iron. We had started iron and folic acid and B12 right on the first day. His appetite improved and he started eating this. His irritability reduced and he wanted to eat a lot of these things. Of course, he was very angry with us because we had stopped all his favorite biscuits and wafers and ice cream. But that was okay. And this is what we did. And what do you think happened on follow-up? Did he lose weight on follow-up?
Probably yes, because of loss of it.
Yeah, he lost 800 grams. And when he came back on after 3 weeks, his proteins had increased. His serum albumin had gone from 0.8 to 4.1. And even the reports say that the serum albumin rises very rapidly as soon as iron is started. So it was, the diet was always there. He was getting 20 grams of proteins from milk, but it was never absorbed. It was lost in the gut. But the simple addition of iron made the albumin normal. But unfortunately, and this is what happened to his growth, his height increased, he lost weight initially. And when he came yesterday, I had to do a lot of mannate to get him back so that I could record his weight, and he had gained weight, and he was back on his normal chart. So he went from 12 to 11.2 and then back to 12.8. And his growth was catching up. And after 3 months, his hemoglobin increased only from 7.1 to 8.8. Any thoughts on that?
Yes, ma'am. Probably we would be more interested in HPLC now.
Correct. Yeah. No, so even now his RDWC is 20, he's still iron deficient.
Yeah,
so,
iron deficient, yes.
Yeah. So there are many reasons why hemoglobin, and even the reports say that although the protein rises fast, the hemoglobin is slow to rise, and there may be other causes as well. So we wanted to rule out cow milk allergy because it would be difficult to rule out, stop his cow milk totally without having hard evidence to say that he has cow milk allergy. Shilpa, I can see your video on. How much time do I have?
Ma'am, you can go for the 5 minutes.
Yeah. So serum IgE levels were high. So perhaps this child also has late onset cow milk allergy, although we know that cow milk allergy comes in the first 6 months. And this is late onset cow milk allergy, and perhaps we'll have to totally eliminate. I had given an allowance of 300 ml, but I think I'll have to stop that. And also to complete the cases, I was telling Mahesh, I'm not comfortable presenting this unless I can rule out celiac disease for sure. So we got the TTG done and it's negative, and also the total IgA is normal. So that's one thing that rules out celiac disease. And because he is less than 2 years, we would have liked to do his DGP, IgA and IgG. The reports are awaited. And I know that it would come negative, but if it does come positive, then of course we'll know what to do next. So if iron does not cause the satisfactory response like it's you would expect, then please check compliance, composition, and these are the preferred ones. Keep a gap between iron dose and meals. Avoid calcium and milk with the iron supplements, or perhaps they should not give milk along. Rule out B12 deficiency. Consider stopping milk altogether like we are thinking. And repeat electrophoresis because this could be iron deficiency along with thiol minor. So once we have got a normal serum iron, and perhaps we should think of correcting his, looking for thiol as well. And so we did consider gluten enteropathy, and we did all these tests. And like you said, upper endoscopy and colonoscopy, once the serum has come to normal, I don't think we should consider that. And in summary, we have this child who had an excess of cow milk intake, who had iron deficiency, associated with late onset cow milk protein allergy, a protein losing enteropathy because of iron deficiency, and an anasaka because of iron deficiency and protein losing enteropathy, which is so unusual. We have learned of so many causes of anasaka, but nowhere have we learned that iron deficiency anemia can cause anasaka because of a protein losing enteropathy. So the challenge today by this case challenge is the challenge of considering iron deficiency anemia due to excess cow milk intake as a possible cause of protein losing enteropathy and anasaka. And other challenges facing pediatricians these days, teaching parents to include healthy and nutritious food rather than tasty and rich food. So not tamasic, but sattvic ahar, and overcoming the culture of biscuits, chocolates, cake, and colas, which is so common, and including the all important micronutrients, especially iron in our diet, by eating more color. So Abhijit very rightly had said in the beginning that micronutrient deficiency, and I congratulate team Abhijit Chaudhary and Sadullah, because I think all that was in this case was discussed by them.
Thank you,
That's all I have to say, and thank you.
Thank you so much, ma'am. That was a very interesting case presentation. And we also got a glimpse of what are the difficulties that we face in convincing the patients for basic tests and investigations in private centers. So thank you so much. Can I ask Dr. Ramakant Patil sir to give his...
So I would like to congratulate Gokan madam, Anjali madam. She took the case very nicely. And also we like to congratulate Professor Dr. Abhijit Chaudhary and Dr. Sadaullah Khwaja. Excellent discussion. What is most important I find over here is that any acute edema, whenever acute edema is there, how are the heart edema and liver edema? It is over a period insidious flow. When a acute edema, we have to find out the cause. Most likely it is a renal or allergic. And this was an exceptional case where there is an acute protein loss. That is what is important. Second thing, that the growth chart was only cross-sectional growth chart. Had we fished out the study, then probably would have come to know that this was otherwise well-grown child. Third most important thing is that any anemia with iron deficiency in our country, if it is in first episode, we'll always say that it is an iron deficiency. But if it is recurrent, then we have to entertain the possibility of gluten or celiac disease. And I will say that there are compulsions, but any elimination of diet, it is a grave thing for doing elimination of diet. Unless until we have got very solid diagnosis, confirmed diagnosis, elimination of diet should not be done. And as madam had come to the diagnosis, it is less likely, because TTGA or anti-endothelial antibodies or DGP, these are again a screening test. These are not the confirmatory test. Here, unless until we have got a biopsy proven diagnosis, we should not go for elimination of diet. So elimination of diet is very important. Again, after ruling out thaltrate or alpha-1 antitrypsin, we say that it is as good as not there in our country. So here in case, what is exclusively a very high milk protein diet. If the parents are very resistant, grandparents are very resistant, what I advise is that it should not be given in place of a solid food. It should be given in place of a water. It should be given as a water satiety for the water, and not in place of the solid food. Probably they understand it that unless until child has had a solid food, they should not be giving milk into this for this child. Also in approach, it was wonderful that it was what are the different causes of edema, particularly acute edema. Renal cause was ruled out. Very rarely we get malnutrition, because height and weight chart had nearly ruled out that this is more like whether it will be protein energy malnutrition or acute malnutrition. Also, the heart condition and liver was nearly ruled out as a cause of edema. Here, one more thing I wanted to highlight is that this child has to be followed up for whether he gets again recurrent iron deficiency. And in that case, this child will definitely need the jejunal biopsies to rule out the diagnosis of celiac disease. Here again, X-ray chest was not entertained or discussed. These are the cases when IG is, there is two types of cow milk protein allergy. One is a IG mediated and another one is a non-IG mediated. So non-IG mediated iron deficiency is called as also, cow milk protein allergy is also called as Henner disease, which will have recurrent anemia, and this iron deficiency causing protein energy malnutrition, and they will have respiratory symptoms. In between, Dr. Abhijit Chaudhary did ask about that, whether the X-ray chest was done. And we'll have that X-ray recurrent interstitial lesions or pneumonia-like picture with iron deficiency. And Dr. Naresh Taide had asked the question in chat box whether the blood transfusion had required in this patient recurrent. No. So if respiratory symptoms, blood transfusion requirement, and resistant iron deficiency anemia, even if IgE is not high, this could be the cow milk protein allergy of IgE mediated. But this will not tolerate even a small amount of milk. They will have recurrent iron deficiency. So here what we take home message is that how is the origin, duration, progress of the edema, which will tell us that whether this is a vascular, allergic or renal edema in case of acute, more of a insidious edemas, which will be again from the liver or kidney, the heart, sorry, not kidney. So, and malnutrition will be evident from the other changes like skin and height weight chart. And what will be the weight for age, what will be the height for age, and in that case weight will be more affected than height for the age. Fortunately, in this child, both height and weight for the age was normal. So it was an uncommon case of acute iron deficiency presenting as a protein losing enteropathy in very short duration. It was wonderfully put forth the diagnosis of hemolytic uremic syndrome also whenever there is history of loose motions, but here we have to find out whether it was definitely dysentery, and which will say that there will be hemolytic, but the point against was then thrombocytopenia. So excellent approach. I will like to follow up this child for the definite celiac disease and non-IgA mediated cow milk protein allergy. I congratulate Anjali madam again and also the participant, and I thank Maha IAP, Dr. Gangolia and his team for giving us an opportunity, and I hand it over to Dr. Mahesh Moite and Rajesh Chokhani sir for their inputs.
Excellent analysis, Dr. Ramakant again. I think all of us are absolutely convinced we had the best judge today who had excellent inputs in his, I think he has covered everything. Maybe when we teach our postgraduates, whenever there is edema, we always divide it into a osmotic edema, that is hypoproteinemia. We talk about hydrostatic edema, that's back pressure on the cardiac. Third, we say about capillary leak, and fourth, we say about lymphatic blockage. Lymphatic block usually is localized. Capillary leak is a sick child of dengue or sepsis. Cardiac hydrostatic is again a sick child. So only thing left in this kind of child is hypoproteinemia. When you talk about hypoproteinemia, you either lose it in the urine or in the stool. Very simple. Here you said child had very acute presentation, otherwise normal, and urine was not going. So obviously he was losing in the stool. So that brings you to an enteropathy of a protein losing enteropathy. Now, few things were unusual in this, that it was very transient, acute, and child recovered reasonably fast. One. Secondly, it has not had any effect, significant effect on his growth. His length is good. Even at 18 months or at 20 months, I would have expected some length affection had it been a celiac like a long-term problem. So unless you tell me the both parents are very tall and mid-parental height is to expect too high, which I don't think so. So probably it's a transient. So I definitely have seen at least a couple of cases where plain simple viral induced enteropathy is a known feature, which recovers also very fast. Here, I totally agree that it was iron deficiency and anemia on the mark of iron studies which you showed. But at the same time, I could not explain that increased RBC count, which is strongly against iron deficiency anemia. So I'll definitely consider a possibility of underlying THAL carrier. And with that, that becomes slightly challenging. So what you showed was something a novelty to us, that plain iron deficiency anemia gives rise to a protein losing enteropathy. We'll definitely keep in mind it's a new thing. One more thing I wanted to say, somebody to get onto albumin of 0.8, I understand the liver is functioning quite well, and when we start losing, you start preparing or producing also very fast. So whether this was really a very short duration or long duration, but as I said, growth is good, so probably we assume it's a short duration transient enteropathy. That's how I come to maybe some short duration insult of virus induced, and that's how perhaps is recovered also very fast. So those were kind of inputs in this case, but nevertheless, absolutely wonderful presentation in this. About the previous case, just one input I wanted to say, you had that rash appearing after 1 month. So wherever we get a new symptom coming at the end of first week or early second week, I say it's a complication of the first primary problem. And when something comes in third or fourth week, I take it as immune mediated unless proved otherwise, except maybe COX, which can come as a chronic infection with maybe pleural effusion coming in third week. But generally that also won't happen so late. So that was a good marker that something which came in the third or fourth week, we could have taken that. And again, a prolonged paper. Rest of the kind of a discussion went very well. Rajesh is there to take it forward. So those were my inputs. Over to Rajesh, if he's there.
Yeah, sorry, my video is not getting switched on. Actually, I think it's been a very long session, so I will not really take too much time. Two very small points. In the first case, just for all of us to learn, when we said that there was a tender liver and a tender lymph node, it ruled out a local liver disease, because a local liver disease like a liver abscess wouldn't have a tender lymph node. So it told us that this is a generalized disease which is affecting liver and lymph node both. And in terms of the LFT, that mild SGPT elevation told us it was a secondary hepatitis and not a primary hepatitis, secondary hepatitis out of whatever cause. So that was one point I wanted to add. In this second case, what I wanted to just add is...
This is what they were talking about.
That was the first case. This is the second.
Yep. Go ahead, Rajesh.
In the second case, the beginning, I mean, why I didn't think it was renal was like this, that we have always been taught that a renal edema which comes suddenly like a nephrotic is always in a well child, and Anjali presented that this was not a well child. So my initial thoughts were already starting on whether he was absolutely all right prior to this, which later Anjali clarified that parents didn't have any problem. But that was very strong reason for me to think this is not a nephrotic. And one reason which I thought as it went along about that growth chart is that this protein loss was not inflammatory in that sense. I mean, if you compare it with a celiac disease on one hand and a protein loss due to iron deficiency on the other, this is kind of non-inflammatory protein loss, and that is why the height was not affected. And that is why that was what my thoughts were. There can be many other aspects of discussion, but I think very excellent cases and excellent conduction. Wonderful, and congratulations to everyone. Thank you.
Thank you.
Thank you. Over to Dr. Ingrid.
Thank you. That was a wonderful session today. And, so we have exceeded the time. So I'll hand over to Dr. Neha for the thank you vote of thanks.
Thank you, Shilpa. And thank you, Sunita ma'am, for giving me this opportunity. On behalf of Maha API, Dr. Neha Singh would like to thank first of all our today's expert, Dr. Ramakant Patil sir. Thank you, sir, for accepting our invitation for being today's case challenge expert. Also, thank you, sir, for your expert comment at the end of each cases. Would like to thank Dr. Rajesh Chokhani sir for his presence and wonderful take-home messages at the end. I would thank both our case presenters, Dr. Anand Deshpande sir and Anjali Kokan ma'am, for presenting such interesting cases today. Both the teams, Team Mumbai and Team Nagpur, for actively participation, brain hunting, and both teams were equally wonderful. Winning is not so important, but participation and active approach is the main purpose of this case challenge. So best wishes to both the teams. I would also thank Dr. Mahesh Moite sir, who is the backbone of this program. Thank you so much, sir, for all your support. Then I would like to thank our Maha IP President, Dr. Hemant Gangolia sir, Secretary General, Dr. Amol Pawar sir, Scientific State Convener, Dr. Jay Bhandarkar sir, and other OP and EB members of Maha IP. Thank you. Thank you, Dr. Sunita ma'am and Shilpa for moderating today's case challenge. Also, thank you, Pallavi ma'am, for technical support. I would like to thank all the attendees on Zoom and YouTube Live for joining us today. Our next case challenge will be on 3rd Friday of August, and that is on 19th. Requesting everyone to please join. While next Friday of July will be our Mahakatta program. Please join. Thank you so much, everyone, and good night.
Good night.
Good night.
Thank you.